Okay, so welcome to our webinar. My name is Jane Schroeder and I lead the policy work here at First Place for Youth. We're really excited today to introduce you to an issue brief that we published this last November called The Dollars and Cents of Becoming a Medi-Cal Contracted Organization, Our Lessons Learned Integrating EPSDT Services into a TAE Foster Care Placement. If you haven't already had a chance to take a closer look at the issue brief, the full brief is up on our website under the tab on publications, and I've also linked to it in the very last slide that you'll see here today, and we'll make this the slideshow available to attendees after the webinar today. So we decided to develop this issue brief and webinar really because of the challenges that we faced while we were attempting to establish an EPSDT program within our existing programs for TAE youth, transition age youth, in particular within our transitional housing placement program for non-minor dependents, our THPP NMD program. So the spirit of this whole project is really to be open with our peers about both the good and the bad, the challenges that we faced, as well as the opportunities that this work presented to improve outcomes with the youth we serve. So we're really hoping that this brief will engage two main audiences: our peer providers who are considering taking on a similar challenge, and in particular those that don't have previous Medi-Cal experience like we were at the start of this whole journey, and also for policy advocates and decision makers who are interested in system reform. And we really just see this brief as a jumping off point. For those of you that are really new to this process, we hope we can help remove a bit of the mystery and help you think through some of the strategic decisions you'll have to make. And from a policy and systems change perspective, we hope to help spark a conversation, or really be a spark in an ongoing conversation about what needs to happen to better meet the needs of the youth we serve and how EPSDT can be a part of that puzzle. But before we delve in, just a little bit of housekeeping. So you are joining as an attendee in listen only mode, so we can't hear you, but we definitely do want to hear from you. So there is a question box on your control panel, and we'd love for you to, if you have questions or comments and feedback at any time, to just go ahead and enter it into your question box. I indicated what this should look like, although I realized I was using a Mac when I took this screen grab, so it might look a little different if you're on a PC, but it should be somewhere on the right-hand side of your screen. We won't answer the questions as we go, but we've reserved a lot of time at the end of the presentation to be able to take questions, respond to feedback and comments. So please feel free to just submit anything as it comes to you. Also, please, if any of you are having trouble hearing us, if we're too quiet, anything else like that, just please enter that there so that we can try to adjust our settings. So the presenters you're going to hear from today are all part of the First Place team. I'll be doing an overview of some of the findings and the tips in the issue brief, and you'll also hear from two of the people that really led this project for First Place. Kathie Jacobson, our Chief Operating Officer, who leads our programs and internal operations since 2014, and really was responsible for spearheading this whole project. And Lauren Grayman, who joined First Place in 2015 and currently serves as the Assistant Director for Programs in Contra, Costa, and Solano counties. And in this role, she's been responsible for the oversight of the My First Place program and the EPSDT services that we integrated into that program in Contra Costa. But this project really was much bigger than First Place. So I do want to take a moment to thank all of our partners in this endeavor. First and foremost, a huge thank you to the Walter S. Johnson Foundation for supporting us, both in for actually pursuing and implementing an EPSDT contract and also in developing this brief. You'll hear later in the webinar, but support from a charitable foundation can really be key in being able to have the capacity to undertake this kind of challenge because of the really huge fiscal risks that organizations are likely to encounter. it was definitely critical for us. And so we're very grateful to Yali Lincroft and the Walter S. Johnson Foundation for seeing the value in this work and supporting us through the ups and downs. And even more than that, especially for supporting us in sharing the lessons we learned with our peers in an attempt to move the field. We also worked with IE Communications, who identified and conducted interviews with some key stakeholders and experts in the field. Those interviews really form the backbone of this issue brief and today's webinar. So thank you to all the interviewees themselves. They're listed on the screen here and also on the inside cover of the issue brief. So just quickly, before we move on to our presenters, I want to make sure that we're all on the same page and that I'm not throwing around too many unfamiliar acronyms at you. So just a very brief and quick overview of EPSDT. It stands for Early and Periodic Screening, Diagnostic and Treatment, and it's the child health component of Medicaid. It's a federal entitlement, meaning that states are required to provide these comprehensive and preventative health services, including mental behavioral health care services, to any eligible child. And that's a child under age 21 who's enrolled in full scope Medicaid. In California, the responsibility for providing and funding EPSDT was transferred to the counties under 2011 realignment. And you'll hear more about that later, but that means that it's the county that's responsible for meeting that entitlement. So this issue brief has a lot more detail on all of these concepts if any of it's unfamiliar, but I just wanted to make sure we at least all have a quick understanding. So without further ado, let's hear from Kathie Jacobson, our Chief Operating Officer at First Place, who again was really responsible for designing this project and spearheading it. Kathie, take it away.
Thank you, Jane. So hello, everybody. My name is Kathie Jacobson. I am our Chief Operations Officer here at First Place and oversee all of our programs, including this implementation. I'm really glad to be here today to talk to you all about First Place for Youth's journey to integrate EPSDT funded services into our programs. As Jane covered many of our thank yous, but I want to add one other thank you before I begin, and that is a special thank you to our partners at Contra Costa County Behavioral Health, who took a big chance on a small pilot. Their support was instrumental as what is sometimes the largest hurdle, and we'll talk about this later on, but one of the largest hurdles agencies face who don't already have a behavioral health care contract is that you are often required to have a behavioral health care contract in order to complete or qualify for one. First Place for Youth provides, and you could go to the mission slide, Jane. First Place for Youth provides intensive, targeted case management to help youth who grew up in foster care as they transition to independence and self-sufficiency. We are an employment and education-focused program with housing at its foundation, which is to say that housing is our first intervention. We work intensively with youth for 2 to 3 short years to flip that equation so that by the time they leave us, their gains in education and wages from employment enable them to sustain stable housing. Working comprehensively, our case managers provide therapeutic coaching, skill-building curriculum, and intensive case management to support youth in housing and the daily tasks of living while increasing their capacity to solve and navigate challenges. It is our firm belief that providing the resources of a social service strategy coinciding with the expertise of behavioral health approaches produces optimum youth outcomes. By the time youth who grew up in foster care turn 18 or 19 and seek support from a program like First Place, they have experienced a myriad of traumas. Most have early histories of abuse and neglect. Many have experienced placement instability. While young adults in our program have had an average of 6 placements, some have lived in as many as 40 different homes by the time they reach age 18. With each of these moves comes a loss of friends, of family, of teachers, of school and therapists. Basically, youth lose everyone and everything familiar when they move, sometimes without much warning. Many feel disenfranchised by their circumstances growing up as a foster youth, growing up as a youth outside of a family, growing up as a youth of color, coming from backgrounds of poverty and disenfranchisement that are cultural, or as a result of their sexual orientation. Most have learned that attachment is transient. Adults are fickle and unreliable and abandon you when you make a mistake. These experiences accumulate, resulting in young people who doubt their own worth, who experience difficulty regulating their emotions, navigating interpersonal relationships, setting boundaries, resolving conflict, and tolerating ordinary frustration, disappointment, or other distress. All of which is to say that young people with whom we are privileged to work have behavioral health challenges secondary to childhoods of chronic loss and trauma. Consider the statistical picture. Around 1/3 of all former foster youth have been diagnosed with at least one mental health disorder, with the most common diagnoses including post-traumatic stress disorder, depression, and anxiety. Many have co-occurring substance abuse disorders. In the general population, rates of youth mental illness, suicidality, and substance use are on the rise. Since 2007, mental health-related hospitalizations for youth in California increased by 50%. Nationally, suicide is the second leading cause of death for all young youth and young adults ages 10 to 24. And yet, at the same time as this need has grown, access to mental health services has remained flat or even dropped and is unacceptably low. Fewer than 5% of eligible youth receive any mental health services under Medi-Cal, and less than 3% receive ongoing services. Integrating behavior health care for foster youth into the existing placements where they are living really makes a difference. We have seen the results in children's mental health when behavior health strategies are integrated into school settings. Services are more accessible. The trauma fatigue that comes with telling yet another new person your story is eliminated. Stigma is reduced. And youth and young people are more apt to engage and stick with services that are connected to a team already known to them. First Place for Youth provides a signature strategy of targeted case management. We work to mitigate the negative impacts of behavior health challenges that interfere with job seeking and keeping, with school attendance and success, and with navigating the daily challenges of apartment living. By addressing the underlying behavior health issues, we advance our mission and the mission of extended foster care more broadly, of helping youth achieve self-sufficiency and independence. Our staff teams are designed to ensure focus on real-life achievement and are led by employment and education specialists, while case managers work holistically to coach youth to overcome barriers. We structure our program to ensure that every young person is seen every week, and we provide specific additional education and employment support to ensure that goal-oriented strategies are front and center, even as we work with young people across all life domains and challenges. Again, we firmly believe that integrated holistic approaches that leverage the strengths of young people and target their individual and unique needs are essential to achieving durable, lifelong outcomes. As an organization, we have actively explored strategies for providing the best services and really been tried to be very thoughtful about how to work best with our county partners to develop successful programs that enable on-site, low-barrier expert services to the young people for whom intervention at this stage has lifelong implications for health and well-being. With this particular project, our goal was to use the EPSDT funded services to enable smaller caseloads for our case managers so that they could provide more intensive services for the most vulnerable youth that we were serving. And also to help meet budget shortfalls because we were basically doing a lot of behavioral health services integrated in our practice and trying to cobble together the funds for that through our social services contracts alone. And this issue brief goes into great detail about the barriers we experienced as an organization that made this strategy such a challenge. And we hope it provides some food for thought for other providers and can add to policy conversations about much needed systemic change. We're very excited to share our journey. We firmly believe that all youth served by agencies everywhere deserve our best strategies, and that braided together, we can by braiding the strategies together, we can ensure optimum achievement of youth outcomes. Thank you. And Jane, I'm going to switch it back to you.
Yep, I'm back on. Thanks so much, Kathie. So next I'm going to hopefully introduce Lauren Grayman again. So again, Lauren is the Assistant Director for our programs in Contra, Costa, and Solano. And as such, she was really responsible for doing a lot of this implementation work on the ground, ongoing and initial implementation. And so she has a ton of knowledge and expertise to share. Today, I actually asked her if she could share a few youth stories that highlight some of the potential that this model has to really make a difference in a young person's life, but also some of the challenges that come up even once an organization has managed to secure a contract and get a program up and running. So Lauren, if you could take it away.
Hi, everybody. I'm really happy to be speaking with you all today to share some insights and challenges that we experienced as we implemented the EPSDT services in our Contra Costa program, in particular to share some of the stories of the youth that we serve. The role that I played in implementing the Medi-Cal strategy was to assist with preparation and planning on getting the physical space ready for certification, attending trainings to be prepared on onboarding the staff that would be doing the work, and to get the documentation in order. It took about a year to be ready to start providing services, and this was a challenging time because of the large scale of information we had to dig through to really figure out what needed to be done and when. Once we had our site certified, staff trained, and the electronic health record system up and running, we were ready to launch. We spent the first year learning from our mistakes on how to best communicate the additional services to our youth, completing documentation accurately, and learning how to integrate these additional services into our program model. Now that we are in our second year of providing services, we've hit a good stride, figured out how to best communicate the service integration and how to accurately complete all that documentation. We're still facing the challenges that come with presumptive transfers, youth unexpectedly leaving program, or aging out of our Medi-Cal contract. And training new staff as they are onboarded has been challenging as well, but we are now enrolling more youth than we have before. We believe that utilizing our clinical knowledge to work within the Medi-Cal system can be a powerful tool to better serve some youth in our program. We see so many young people that face a mental health diagnosis and that need extra guidance and support. They have so much potential to define and reach their life goals, but they face barriers that are related to their diagnoses. And they need help treating their symptoms and learning healthy coping skills and strategies to help manage the diagnosis. Using EPSDT as a funding source to provide this heightened level of care can increase stability in our program and allow for advancements towards independence and self-sufficiency goals. Still, implementation is not without major challenges. In addition to the more technical and logistical challenges we face getting this program up and running, providers have to realize that they will also face challenges in actually ensuring that the youth access the services offered. As a TAPE provider, the population that we work with are all legal adults who have the right to refuse mental health services. And providers have to be mindful that the stigma associated with mental health, negative experiences youth may have had with mental health professionals in the past, and other factors like this might make youth reluctant to accept the services. I would like to share two stories with you today to illustrate these opportunities and challenges. The first youth I'd like to speak about is one of our more challenging cases, and a case where staff have worked very hard to really try to increase services in the hopes we could assist her in overcoming some of her previous traumas. Jade is an 18-year-old female who entered the foster care as an infant after her mother tested positive for drugs at the time of her birth. She remained in care for her entire childhood, bouncing around between many different placements. For Jade, her time in foster care and group homes was characterized by more trauma as she became the victim of physical, verbal, and sexual abuse, as well as neglect. During her adolescence, Jade began engaging in self-injury and cutting behaviors in order to cope with the pain and pressure she felt. Jade was trying to deal with feelings that seemed too difficult to bear and to deal with bad situations she thought would never change. As a result of those behaviors, Jade was introduced to several different mental health professionals during her time in foster care. Jade says that she felt let down by the system. She would build a relationship with a therapist only to have her placement change and have to start over with a new provider. The cycle was overwhelming and re-traumatizing. Jade joined First Place about a year ago, and since then, staff have worked hard on trying to build authentic relationships with Jade. Staff observed that her depression and anxiety symptoms impacted her daily life and her ability to progress towards her goals, along with her ability to connect with people. Jade's team at First Place have consistently worked from a strengths-based perspective, being supportive, consistent, and trauma-informed in their attempts to build relationship. But Jade's emotional wounds run deep, and she resists trusting staff or building relationships. When staff approached Jade about opting into the EPSDT program, Jade refused, citing her past negative experiences with the mental health field. Although we continue to provide Jade with weekly team-based support, her depressive symptoms are still a barrier, and her team are concerned that without additional mental health support, Jade will continue to be at risk. Because of the population we work with at First Place, we meet youth like Jade often, youth that have provider fatigue, youth that claim the independence that comes to them at 18, and at the same time turn away from the support that is also available. Part of implementing an EPSDT program as a TAPE provider is understanding how to navigate these circumstances, communicate with young people about the services offered, and work to destigmatize care. For us, this has been a work in progress. The next youth I would like to share about is Kylie. Kylie has been in program for a year and a half. When Kylie was 12, she began using drugs and engaging in illegal activities in order to feel a sense of control over a life that felt unstable, unpredictable, and chaotic. This ultimately led to her being in juvenile hall, followed by group homes when it was unsafe for her to return home. Kylie joined First Place at age 18, coming directly from a group home setting. She was motivated to work on her education goals and wanted stable housing and support from a team of people. Still, when her First Place team started meeting with Kylie, they observed that she had symptoms of depression, including lack of focus, excessive hunger, loss of interest in activities, sadness, discontent, and irritability. After discussing these observations with Kylie, she and the team agreed it would be best to enroll in our Medi-Cal program. Kylie was working full-time and was excited to know that this option existed. She didn't like the idea of having to search for an outside therapist and add more appointments and locations to her busy schedule. She was relieved to be able to work on addressing these symptoms with her First Place team, with whom she had already built a strong relationship. Since enrolling in the Medi-Cal program, Kylie and her team worked in partnership to help create more structure and a platform for her to address her depressive symptoms. Kylie says that she's become more aware of how her behaviors relate to her traumatic past and also how they can impact her hopeful future, and she's learned how to effectively manage her symptoms. Kylie's team has seen significant growth in the last 6 months. Kylie is currently working full-time at a local bank, is planning on returning to school next semester to pursue a degree in criminology, and continues to impress staff with her insightfulness and plans for her future self. We've also seen an increase in her ability to manage healthy interpersonal relationships, manage stress, and be more emotionally regulated. We hope to continue our work with Kylie until her 23rd birthday, when she will graduate from our program and into an independent and stable environment she has worked so hard to create. Kylie having access to these sorts of services at First Place, rather than having to seek outside treatment in yet another setting, really removed barriers to getting Kylie the care she needed. These two stories illustrate the great potential, but also the unique challenges of integrating EPSDT services into a program for transition age youth. Despite the challenges, it is the success stories that stand out and motivate us to pursue this strategy. Thank you.
Thank you so much, Lauren. Okay, so now that we've had a chance to get some background and framing on this issue from the folks that were really leading the project at First Place, I'm going to get into the nuts and bolts of it and talk about just some of the key takeaways tips and food for thought that are in our issue brief. And again, the link to the full issue brief is going to be on the last slide of the presentation, which will be made available after. And it's also already up on our website under the tab on publications. So we definitely encourage you to take a closer look, especially if any of this webinar sparks your interest. So the issue brief that we produced, unfortunately, it's not a cut and dry, how-to guide. And this is really because of the complexities that we uncovered along the way. And what we found in our journey to becoming an EPSDT provider and integrating services into our TAE programs is that the risks and the uncertainties are really great. And as a result, it might not always make sense or just even be feasible to enter into this space, even where there is a great need. So for us, we initially expected that we'd be seeking out contracts in all 6 counties where we operate. And after our experience with the first one, we decided to pause that strategy and take stock. And we still are exploring those options because we really do believe, like Kathie and Lauren both were illustrating, we really believe in the value of integrating behavioral health services into TAE placements. And of course, those services do need to be funded. And as it stands, providers like First Place are often doing this work, but relying heavily on essentially augmenting their foster care placement program rates using private fundraising dollars and other sources, which might not be as sustainable. But nevertheless, after our first experience doing this, we did decide that we needed to take a step back. We wanted to examine why it was so difficult for an organization like ours to get involved in this work and do this work, and what that might mean for similarly situated organizations, and especially even smaller organizations who might be thinking about taking on this challenge, either because they want to meet an unmet need that they recognize in their community or service population, or even because they have to do so under CCR. And ultimately, what do these barriers that we experienced and other providers experience really mean for the young people that we serve? From a systems perspective, one of the reasons we wanted to put out this issue brief is to contribute to ongoing conversations and discussions about how we can meet the needs of non-minor dependents. And if you're unfamiliar with that term, that's youth over age 18 who are in extended foster care. So non-minor dependents who have higher mental health needs than the placement programs and rate structures we currently have were really intended or designed to be able to address. There is an increasing awareness among providers, advocates, and other stakeholders that our current continuum of placement settings in extended foster care really isn't adequate to meet these needs. And this is leading to instability within extended foster care, and it's leading to poor outcomes for youth, including housing instability and homelessness. So this is a serious gap in the system. And as an organization, we're really invested in trying to understand and ultimately fill that gap by experimenting with different programming and by moving policy at the local and state level. One idea that's sometimes put forth in these sorts of conversations is to use EPSDT contracting within transitional housing placements for non-minor dependents in order to sort of bridge that gap, essentially using it as a form of, sort of an enhanced placement setting for youth with higher mental health needs. And in some ways, that's sort of what we were hoping to accomplish on a much smaller scale with this project. And coming out of this experience and this research, we do still believe that EPSDT needs to be and can be a part of the solution to the service gaps that exist for TAE foster youth. But the fact is, it's very, very far from being a simple solution. And unfortunately, it probably can't play a major role in improving TAE placements and outcomes unless there's some systemic reform, particularly around Medi-Cal certification, EPSDT contract procurement, and initial implementation. So right now, the barriers to actually becoming an EPSDT provider in the first place, particularly for TAE providers, make it highly unlikely that there could be widespread adoption of this resource and this model in transitional housing placements for TAE foster youth. It's just not a realistic option right now, and that's a problem. So the operational challenges of becoming an EPSDT provider are immense. And as you just heard from Lauren, there's also significant challenges with ongoing implementation and actually doing the work on the ground. And that includes barriers that arise with youth related to stigma and consent. In this issue brief, though, we really chose to focus on some of the key challenges that organizations are likely to face, even getting a foot in the door. Based on the interviews conducted by IE Communications with experts and stakeholders in the field, as well as our own experience, we think that the barriers that kind of complicate the integration of EPSDT into TAE placement settings fall under two major, very much interrelated umbrellas. The first is related to fiscal challenges and risks that are borne by the provider. And the second are barriers related to contract procurement, particularly for newer and smaller providers. So first off, the fiscal challenges that can relate to costs, risks, and barriers to sustainability. Initiating a behavioral health strategy that's supported by Medi-Cal billing requires an enormous investment of agency resources. There's really no way around that. And in fact, for some organizations, they might find that the costs are just prohibitive. There are just a ton of costs that are associated with feasibility, contract development, site readiness, infrastructure, staff training, investment in an electronic health record system, just to name a few. But what makes these investments so inherently risky, such a big risk for an organization, is that most of them are upfront expenditures. They have to be taken on with no guarantee of actually procuring an EPSDT contract. So basically, in order to effectively compete for a contract in the first place, a provider has to be ready to demonstrate their capacity to meet Medi-Cal certification requirements for a particular county. So this includes investing in necessary infrastructure, hiring appropriate licensed clinical staff and compliance personnel, purchasing an EHR system that meets county specifications, and other requirements depending on the county and the landscape there. The prospect of having to cover all of these costs with no guarantee of actually procuring a contract is intimidating, to say the least, and might keep qualified providers from even entering the field. So during the rest of the webinar, we're going to talk a lot about the barriers to contract procurement specifically, but suffice it to say, it can be very, very difficult to actually get a contract. So this is by no means a small risk for an organization to take on. And in addition to that, there's fiscal barriers that come up when it comes to scale and sustainability. For a lot of organizations like First Place, making this a financially sustainable endeavor over time would require growing to a certain scale, enabling the startup costs and the overhead and compliance costs to be spread out over a broader service population. For us, this would have required operating in contracts in multiple counties, and particularly in counties where we serve a larger population of EPSDT eligible youth. But even if you're able to get a contract in one county, the contracting barriers that we're going to be discussing soon make it extremely difficult, or at least very uncertain, whether you'll be able to actually expand to further counties. So this can put sustainability in question, and again, leaves the agency in a very risky position. So for First Place, the most critical support in mitigating these fiscal risks came from our partnership with the Walter S. Johnson Foundation. That partnership enabled First Place to pursue an EPSDT contract and provide these enhanced services that otherwise might have been out of reach or just too much of a risk. When it comes to confronting these challenges, our first piece of advice is just to proceed with great caution. Realize that there is significant risk, that the process is extremely complicated, and that the benefits could be limited depending on implementation and other factors particular to the setting. So before beginning the process or making any investments, your organization really should consider performing a very thorough cost-benefit analysis. You'll want to consider each of the counties where you operate and their different policies and procedures, as well as your relationships there, the landscape of services and providers there, and the likelihood of you getting a contract. Some things you might want to consider are the size of your EPSDT eligible population that you serve in a given county. For instance, if you're a TAE provider that operates both a THPP NMD and a THP Plus program, recognize that only the THPP NMD youth will actually be eligible for EPSDT services, since those are typically the youth that are under age 21. And sorry for all those acronyms. You'll also want to consider where, if anywhere, you already have pre-existing Medi-Cal contracts, because that can give you a leg up in getting future contracts. Another factor you'll want to include in your analysis is the scale that you would need to reach in order to achieve fiscal sustainability and the likelihood of reaching that scale given the service type, the eligible population, and various barriers to contract procurement. So you can find more detail about each of these factors and considerations in the issue brief itself. But moving on to another recommendation, another thing you might want to do is to seek out philanthropic partnerships like ours with the Walter S. Johnson Foundation. These kinds of partnerships and investments can really provide instrumental support. Investment in planning and startup grants, it enables providers to really hone their strategies and test out new and innovative models without compromising the quality and the stability of their existing services. So again, we're so grateful to the Walter S. Johnson Foundation, and we would encourage also other foundations and funding partners to consider these kinds of investments to help providers get up and running and to meet an unmet need in the community. They're not always the most popular kinds of grants, but they're so very critical. As a provider, you'll also want to consider relationships with county partners and just make sure that you're engaging in those conversations from the outset. First Place began active conversations with Contra Costa County at least a year before actually pursuing a contract. And the point of this dialogue is to really make sure that you understand the county and community needs, the missing pieces that your agency might be able to provide, and the county's goals and their pressure points before you invest a lot of funds into the proposal. Just to really make sure that you're competitive and that you're offering something. From a systems perspective, though, we also need to think about how some of these costs and risks can be spread out or shared, particularly to ensure that smaller providers and providers that serve underrepresented or marginalized populations can have a fair shot. So this could look like establishing grant programs to fund startup costs for organizations that serve underrepresented groups, or even encouraging counties to contribute to startup costs, particularly when a provider is agreeing to step up to the plate to fill an unmet need or fill a gap that the county ultimately is responsible for. All right, so now moving on to barriers in contract procurement, which was kind of the big one. Our interviews with stakeholders revealed that this general problem or barrier can be broken down into some key themes. The inconsistency between counties and their contracting practices and certification practices, disadvantages that show up for providers that are new to Medi-Cal, barriers to initiating smaller contracts, and fiscal concerns and confusion under realignment. So we're going to just quickly look at each of these in turn. When it comes to contract procurement, one of the biggest barriers by far is the huge inconsistency between counties. When an organization obtains Medi-Cal certification, that certification is valid for one specific county, one specific location, and one specific set of services. So this would be less of a logistical dilemma if there were standardized procedures and practices across counties, but that just isn't the case. And the same goes with contracting policies. These are set by individual county board of supervisors, and there isn't a statewide standard. As one interviewee said, you know one county, you know one county. It's really not a huge exaggeration to say that there are about 58 different sets of rules, policies, and procedures. And this can make it really, really difficult to find solid guidance on how to go about becoming certified and securing a contract. But also for organizations that are operating in multiple counties, this entails huge challenges in operations, in costs, and in growth and sustainability. There's a lot of factors and complications that come up because of the inconsistency between counties, but one that really stands out is the issue of the electronic health record systems, or EHR systems. An EHR system essentially is a digital version of a patient's paper chart that is maintained by the provider, and it contains patient information, medical history, progress notes, and that sort of thing. Medi-Cal certification requires the adoption and use of a HIPAA-compliant EHR system, but again, there is no statewide standard. And so counties have opted to use different systems from one another, many different systems. And this is a huge problem because the purchase and implementation of an EHR system is definitely one of the most expensive and challenging aspects of certification. Also, the operational and fiscal costs of training staff to use the system. So providers serving youth across multiple counties, they might have to incur the cost of adopting multiple systems and providing staff training on each individual system and doing duplicative data entry. And there might be some solutions to this, some creative solutions, and we do address some of these in our brief, but there are none that are without any sort of costs, operational challenges, cultural trade-offs, and other issues. So what can be done given this huge discrepancy between counties? From a systems change perspective, stakeholders need to investigate whether and how to go about establishing uniform statewide standards, procedures, and tools for Medi-Cal certification and EPSDT contract procurement. And maybe most importantly, this would include adopting a uniform EHR system. Also, though, whether there's a standardized system or not, what we've heard from our interviewees is that navigating the world of Medi-Cal certification and billing is extremely complicated, and it requires more than just a training. It really requires ongoing coaching that's individualized or tailored to an organization. And at this point, that entire burden is really borne by the provider. So one interviewee, for instance, suggested that counties especially counties who are contracting out a significant percentage of their EPSDT services, should establish a system to offer not just training, but ongoing coaching to their provider partners, especially, again, those that are stepping up to serve communities that had previously unmet needs. In the meantime, though, there's some practice tips you can consider given the discrepancy between counties. The first, just recognizing that this is the case, just knowing that there's an inherent limitation to all the materials and trainings that are out there that discuss the steps to becoming an EPSDT provider, but that aren't county specific. So as soon as possible, you'll really want to be particularizing your research to an individual county so you don't waste resources or potentially act on misinformation. Another thing is that it really is a wise idea to, if it's possible, to hire staff or bring on an outside consultant that has extensive Medi-Cal experience. And ideally, this would include experience procuring and administering Medi-Cal contracts in the specific county or counties where you're looking to operate. These processes are really complicated, and doing this will give your organization much more confidence and security. And also, it'll likely give the county a better sense of security in choosing to work with you as a provider. When you're looking for a new staff person or consultant, you could even consider, hiring somebody who has relationships and ties to local behavioral health agencies, because that could prove helpful in identifying potential opportunities and coordinating potential opportunities for a contract. Another major barrier to EPSDT contracting is that new providers are at a pretty severe disadvantage. And when I say new providers in this context, I mean providers that are new to Medi-Cal specifically and not necessarily to their other service areas. One interviewee that for this issue brief said that the best way to get a Medi-Cal contract is to have a Medi-Cal contract. So that's possibly the biggest catch-22 to this whole process, and there are a few. So this disadvantage for new providers shows up in both implicit and explicit ways. County contracting processes tend to favor providers with existing Medi-Cal contracts. During the RFP or request for proposal process, a county may even award points based on prior experience administering a Medi-Cal contract. And we should note that this is not entirely without reason. We do have to take into account that counties have very legitimate concerns around experience and expertise. They want to be sure to contract with providers that have the know-how and have the capacity to effectively implement and accurately bill for Medi-Cal services, especially because the risk and the cost of improper billing are borne by the whole system, not just by the individual provider. However, whether intentional or not, one effect of this is that larger, more established providers are encouraged to keep expanding, whereas smaller providers can struggle to even get a foot in the door. So several stakeholders described it as feeling a bit like an old boys club. And unsurprisingly, this can have a disproportionate impact on smaller, community-based organizations, and particularly those that might focus on specialty populations or underrepresented groups. So in terms of practice tips, as a provider that's new to Medi-Cal, like we were when we started out, I just want to reiterate how important it is, if possible, to hire a staff or an outside consultant that's well-versed in behavioral health contracted services. Having that in-house expertise will really provide so much value to the organization just in navigating these kind of choppy waters, and it can really decrease the fiscal risks that the organization will face during the inevitable learning phase. For a provider that hasn't had a Medi-Cal contract, this is key because there definitely is a learning curve. We experienced at first place, even with experienced staff on board, there's still going to be mistakes and some trial and error. So the more this can be minimized, the better. At the same time, bringing in internal or at least external expertise can be instrumental in assuring a potential county partner that the provider will have the capacity to manage, deliver, and accurately record and bill for Medi-Cal services. And this can make an organization more competitive in the bidding process since counties are looking for that prior experience. Someone, again, with prior relationships to county behavioral health agencies can be especially helpful. From a systems perspective, though, we need to be exploring and implementing reforms that would increase accountability and ensure that the procurement process is clear and transparent and that it's fair and equitable. Counties might want to rethink experience points, for instance. Even though there is value in experience, it needs to be balanced with other important factors like having a diverse and inclusive array of services and provider types, and assuring that there are trusted community-based options, particularly for marginalized groups. Counties might consider balancing out experience points by awarding points for organizations that are serving underrepresented populations. And in general, they could apply a diversity, equity, and inclusion lens to their contracting practices. The third theme that we heard about when it comes to contracting barriers is related to scale and reluctance to initiate smaller contracts. During the decision-making process, there's a lot of kind of overlapping factors that could influence county contracting preferences in a way that tends to disadvantage smaller contracts or smaller providers. And it's unfortunate because, again, a lot of those smaller specialty providers are intentionally focusing on a particular disenfranchised or vulnerable population that's possibly underserved or less likely to be able to take advantage of the more traditional services. So for one thing, counties might be reluctant to administer smaller contracts just due to the relatively high administrative burden that this can entail and the risk to the system if services are billed improperly. So again, it is a legitimate concern. The other thing we heard from the county perspective is that, counties are having to make these contract decisions from a macro perspective. They're considering the entire behavioral healthcare system in that county, the range of contracted providers, and the availability of services for various populations. And from this perspective, counties might be disinclined to award contracts to providers that serve a relatively narrow population, as opposed to those that can meet a broader range of community needs with one contract. It's sort of a two birds with one stone type of mentality. There's this general perception that counties would rather give one contract to one general provider rather than multiple contracts to providers who support specific subpopulations. And finally, county contracting is often perceived as sort of a winner-takes-all game, meaning that if one provider and their service population receives the EPSDT contract, another will lose out. This is very much related to our next theme, which covers fiscal concerns under realignment. So fiscal concerns under realignment, or whose bill is it anyway? This is probably the theme we heard about the most in the interviews from stakeholders as being a persistent barrier, and we often heard it referred to as being sort of the elephant in the room. So this is not just the issue of realignment itself, but how it interacts with the provision of EPSDT services as an entitlement program. So like I mentioned in the very beginning, the EPSDT benefit is a federal entitlement, and that means that counties, as the entity responsible for administering the benefit, they're required to offer those services, provide those services to all eligible children without any caps. And counties are also required to have enough services available, either by offering them in-house or via contract with private providers to meet the needs of the entire eligible population. So no counties are explicitly placing a cap on the services they provide or the number of contracts that they're entering into. In practice, though, this just doesn't seem to be the case. There are eligible children who are not accessing services or who are languishing on wait lists, and there are providers who want to serve those youth but can't seem to procure a contract. So what's really going on? In our stakeholder interviews, we heard again and again a concern that counties are maybe limiting their EPSDT expenditures, essentially treating it as a de facto capped program, which of course would be a violation of federal law. And a common theme or understanding is that this tendency traces back to 2011 realignment and growing fiscal concerns on the part of counties following that agreement. So under realignment, the responsibility to provide and pay for EPSDT services shifted from the state to the counties, with the state providing an allocation from dedicated tax revenues that was based on historical spending and demographics in each county. And the state, in turn, is responsible for reimbursing the federal share of county costs using federal Medicaid and general state funds. The problem seems to be that following realignment, counties have become increasingly concerned the state might not reimburse expenditures that exceed that initial allocation, even if they're made on behalf of eligible youth for medically necessary services. And in general, there's just a lack of clarity among stakeholders about exactly where this responsibility lies. And in reaction, whether implicitly or explicitly, some county finance departments may be hesitant to expand EPSDT services or initiate new contracts, at least without a very, very clearly demonstrated community need. So this concern and this tension, it feeds into an implicit attitude that EPSDT contracts are sort of a zero-sum game, meaning that one provider or their service population gets a contract, another will miss out. It shouldn't be the case, but it does seem to play out that way. Since counties are incentivized to initiate as few contracts as possible, then they may end up disadvantaging smaller, specialized providers that serve underrepresented or marginalized groups in order to contract with larger organizations that are less specialized, but that serve a broader population, regardless of whether those services are really best designed to meet the access needs of all populations. So given this very complicated and fraught landscape, it's really particularly imperative for providers to make their case to a potential county provider. And what this comes down to is really thinking about the whole picture and being able to make a clear case for the unique needs of your service population and demonstrate how your program is a critical addition to the spectrum of services and programs that are already available. So you want to think about the unmet needs in a county and the county's pressure points, like meeting utilization targets, so you can pitch a partnership and really engage in a collaborative process. First Place was able to secure a contract in Contra Costa partly due to a recognition on the part of our county partners that transition age foster youth or non-minor dependents are a particularly vulnerable population with very unique service and access needs. And that understanding, it came about through collaboration, communication, and education over some time. So ultimately increasing that kind of collaboration between behavioral health departments, community-based organizations, and social services will result in better outcomes for transition age foster youth and other at-risk youth. On a systemic level, though, counties really need clear guidance from the state affirming that EPSDT is an entitlement and guaranteeing that counties will be reimbursed from this for the state share when they exceed their initial allocation in providing those medically necessary services to eligible children. In other words, I mean, the state basically needs to assure counties that EPSDT service delivery won't become an unfunded mandate. And at the same time, stakeholders and advocates may want to encourage counties to reserve a portion of contracts for smaller agencies and community-based organizations that provide specialty services to underserved, vulnerable populations, or which are representative of those communities. Regardless of who picks up the bill, the underlying fact remains that this is an entitlement program and counties are responsible for delivering it. That's the deal under realignment. So it's very important that this doesn't become a de facto capped program like it seems to be doing in some areas. So counties need to be held accountable too for identifying at-risk populations and ensuring that they have contracts within their array of providers that are designed specifically to meet those needs. And this includes contracts with transition age foster youth providers. And one last thing I want to touch on that's related is it's just the issue of the THPP NMD rate, which is the rate for the Transitional Housing Placement Program for non-minor dependents or foster youth over 18 in the extended foster care system. Part of what we're finding is that the rising housing costs are really starting to starve the service portion of the rate in these NMD programs. And so this just increases the reliance on private fundraising or has organizations scrambling to figure out how to make ends meet while really actually serving the youth that are in their programs. So one thing that would help relieve the tension on this whole system is to increase the rate based on the actual housing costs, and also enhancing the rate to allow providers to serve youth with higher needs, and to allow them to do so flexibly so that they can really individualize their services to the youth that they have in their program. Doing this would help alleviate the tension that providers are experiencing in meeting the needs of their population. So that's kind of an overview of the main tips and points that are in the brief and some of the main barriers that we experience and that stakeholders are observing in the system. We did reserve time for questions, but I have not seen any come in yet. I'll double check that I'm not missing them. But if anyone has a question, you can type it into the question box on the right-hand side of your screen, and we will happily answer it. But I'm not seeing any. I think I see a hand being raised. So it does give you the program does give you the option to raise your hand. But if you wouldn't mind just typing the question in, because I can't actually switch the control to allow you to ask the question. Yeah, I see a couple hands being raised. Okay. Sorry, just give me 1 second. Okay, so someone said for those that are on a PC, you need to click the orange arrow that expands the control panel in order to ask a question. So that might be part of the problem because again, I did the screenshot in the beginning of the presentation from a Mac, so it probably looks different for those of you that are on a PC. Somebody asked, is it possible to determine what has been the predominant EHR software being used? Kathie, is that something that you might be able to answer?
Can you ask that again?
Sure. Is it possible to determine what has been the predominant EHR electronic health records software that's being used?
Great question. And a lot of times what you see is counties using NetSmart, but NetSmart has three or four different versions, and they don't talk to each other. So in Contra Costa County, where we have our first contract, they selected their software during the time that we were working with them. We actually ended up choosing to use a software called Best Notes that gave us the ability to just sort of pay per user. And that does have very useful ways of gathering the information in order to report for funding, and is an approved provider by Contra Costa County. The trick is you've got to get your software approved by the county so that it meets all the HIPAA regulations and any county regulations they have for keeping electronic records. But Best Notes is one that's approved by a lot of people and is more affordable and can upload to some systems. So there isn't really one thing that most people are using, unfortunately. It really is county by county.
Okay, so we got a few questions coming in. It looks like some people are still having trouble with the hand button versus the question. But somebody is asking about the script that we're reading from and the slides and what will be made available. So the slides will definitely be made available. And then in terms of what we've all been saying, there's also going to be a recording of the presentation. So we'll make that available, as well as the issue brief itself actually goes into more detail. So, a lot of what's being said in the presentation is taken from the issue brief. So if you are interested in learning a bit more about our experience and about the perspectives of the stakeholders that were interviewed, then I'd really encourage you to take a look at that issue brief. It's on our website, and it's also linked on the last slide. Actually, I haven't pulled up the last slide, but this slide, if you click on the link of the issue brief itself, the icon, then that will bring you to the issue brief. And again, we'll send out the PowerPoint presentation after the meeting. Okay, so somebody else said, what are the top 3 reforms that you would like to see happen and that can fairly quickly be accomplished in the next year? So I'm not sure about the part of whether these can be fairly quickly accomplished in the next year, but I think probably one of the top reforms that we'd like to see happen would be the establishment of uniform standards and procedures for Medi-Cal certification and EPSDT, well, for Medi-Cal certification and specifically the electronic health records system. As Kathie just mentioned in answering our last question, there really is so much variability and it just complicates things a lot. And in a way, that's a relatively simple fix, but actually, what it would take to accomplish that in the next year, I think it might take quite a bit more than that. But I do think that would be a top reform. And likewise, an increase in the transparency. Oh, sorry.
Yeah, I was going to just add a couple if I can, Jane. I thought you were done.
No, go ahead.
So I think that some of the other things have to do with making it more easy, particularly for young adults that we serve who move frequently, to be able to get services where they live. So there is legislation that was passed that is the presumptive transfer legislation that Jane talked about, but it doesn't work well yet, and I think that there is some opportunity to improve that or to make it easier for young adults to switch their Medi-Cal to the place that they live. So really, as far as eligibility is concerned, doing some lifting around the county by county barriers that young people experience would be great. And I think that the other one is to really work with our, with state folks to be able to, because it's an entitlement, but it ends up being capped because of the way money flows from the state to the counties with realignment. And so to really do some work about what would it take to be able to open the gates a little bit more widely so that young people who need services are able to get them, and that we don't have arbitrary caps based on what happened last year, but we have a real ability to implement the entitlement.
I definitely agree with that. And I think another thing that just needs to be worked on, especially if we're talking specifically about TAY programs and integrating this into TAY placement settings for foster youth, is coming together to really come up with some solutions that will make it easier for smaller programs or programs that serve a smaller population to be able to get these contracts, to integrate them into those service models, because we are hearing a lot about how this could be one of the tools in our toolbox for addressing the issue of unmet mental health needs within that population, and specifically the way that those unmet mental health needs are contributing to instability within those programs and contributing to the problem of youth homelessness. So it really should be part of the solution, but in order for that to happen, there needs to be more access also for the providers themselves. So I think there's a lot of things that could be done. It could look like a grant program. It could look like applying more of a diversity, equity, and inclusion lens into how these contracts are actually awarded, but I think something to really address that issue so that this can be a meaningful part of the solution is going to be critical. Okay. Let me see. And I'm sorry, it's actually surprisingly hard for me to see these questions. I'm having to kind of scroll on a very small little screen, so that's part of why it is taking me a while. So somebody asked, can you explain more on the 2011 realignment and the impact that it has on funding? Kathie, you were just talking a little bit about that. Do you want to address that more or have me take that?
Well, I don't actually feel like I'm an expert on realignment. And I do think that there's some folks out there. I know that we've got some folks from the California Alliance on the phone or on the webinar, and I think they've done tremendous work to understand and look at how this works and impacts and how to sort of fix the intended and unintended consequences that are challenging with it. But the bookshelf version of it is that realignment meant that the dollars that would flow from the way that mental health services were paid for prior to 2011 is that the counties chipped in 5% of the cost, the state chipped in 45% of the cost, and the feds chipped in 50% of the cost. With realignment, the state dollars for all services, so emergency services, ambulance, fire, and behavioral health and health services went to the county as a lump sum, and the county decides how to spend that across the needs that the county had. So all of the state share of all of those different kinds of things were pooled together and given to the counties as a lump sum for the counties to then figure out how to spend them within their county. So the county's share of cost for Medi-Cal services went up. The county presumably got those dollars from the state, but the county got them as one pot, but they also had to pay for fire departments and road repairs and other really essential services within the county as well. And so it created a conundrum in terms of managing it, whereas prior to realignment, the dollars would be set aside in the state budget and earmarked specifically for behavioral health care in the way that they were then distributed to the counties. That's the nutshell version. And again, there are people with so much expertise and who have done so much work in this area that I want to be really cautious about saying that there's a lot better resources for that information.
Thank you so much, Kathie. So I'm actually not seeing any other questions coming in. If anybody has some, please do type them in now, because we'd be happy to to address them. And again, in case it's one of you that's having trouble with the hand versus a question box, someone had written in saying as an FYI that on a PC, you have to click the orange arrow that expands the control panel in order to ask a question. So that could be helpful for you. And in the meantime, I just want to kind of go back to one thing. I wasn't sure how many questions we'd get, so I didn't talk about this quite as much, but also related back to, what are some top reforms we'd like to see that could be accomplished in the next year or so. One thing, and this is, again, this isn't a reform of the Medi-Cal contracting or EPSDT services issue, but it would actually relate to our ability as transition age youth providers to increase services and increase the intensity of services to meet the needs of youth who have higher mental health needs. And that would be augmenting the rate for the transitional housing placement program for non-minor dependents, both to reflect an increase based on regional housing rates that currently are just starving the service portion of the rates and really making it difficult to provide the services that go, above and beyond the sort of bare minimum that was contemplated by the rate, but also to enhance the rate to meet the needs of higher needs youth, not just youth with mental health needs specifically, but also other factors that can kind of contribute to why it might be more difficult to keep a youth stably housed and stable within that placement program. And that is something that we're going to be working with a group of advocates on pursuing in the coming year through a rates work group process. So if that's something you're interested in being involved in, definitely reach out to me. But we are hopeful that we'll be able to make some progress this year on that issue. And that, again, that would remove at least some of the tension that TAE providers are experiencing in trying to meet those needs. All right, so it looks like there are no more questions unless I'm missing anything. So I am just doing a quick scroll to make sure, but that is it. So we're going to wrap up a little bit early. Like I said, this is my first time actually using this webinar service, so I'm not sure exactly how it's going to come through, but I am sure that I am going to be able to get you guys all a copy of the slideshow and access to a recording of the webinar today. And when that gets sent out, we'll be sure to include the link to the issue brief itself. And like we all said in the beginning, we really do hope that this will be part of an ongoing conversation that we're having as providers, advocates, and stakeholders about what needs to be done to better meet the needs of the young people that we serve. So thank you guys so much for participating in the webinar today, and I look forward to working with you all more on this issue in the future. Have a great rest of the day.